Good afternoon, or is it good evening, everybody? Thank you, Bashir, for those kind words. I'm very impressed by this conference that is going on in this very well organized. Bashir, Twahir, and Were, you've done us very proud. So I've been asked to talk about challenges of pediatric nephrology in developing countries, but it's so interesting that yesterday, Professor, what's the name of Ike? Felicia actually gave my lecture. And so she's made it very easy for me. Basically, that is the outline. Now, we know that in many developing countries, pediatric kidney diseases are usually undiagnosed. And this is due to lack of awareness in the parents, the communities, and also the medical personnel. We know that there's a scarcity of trained personnel, that's pediatric nephrologists, and even the pediatricians, we do not probably have enough. So I want to read you this from the WHO about social determinants of health. The social conditions in which people live powerfully influence their chances to be healthy. Indeed, factors such as poverty, social exclusion and discrimination, poor housing, unhealthy early childhood conditions, and low occupational status are important determinants of most diseases, deaths, and health. And this happens not only in low-income and middle-income countries, it also happens within the big cities, within developed countries, where you have poor people living under very bad conditions. This is a nice diagram that actually summarizes all those things about socioeconomic, cultural, environmental conditions. We know that in Africa and Asia, we are seeing a very big explosion in population, and this is actually happening amongst our young people. In Kenya today, I think I can tell you that people who are under maybe 25 are more than 65% of this population. And so we have to really pay more attention to the services that we are offering them. And you can see that the life expectancy is different in different parts of the country. You can see that the life expectancy is very high in North America and also in some parts of Asia, but is very low in Africa. And this is because of the scarcity of infrastructure and low economics, so that we cannot provide state-of-the-art health services. So kidney diseases, both acute and chronic, are major public health issues worldwide. More than half of the patients with advanced chronic kidney disease do not receive any treatment, especially in low and middle income countries. They're just dying there. One, because they don't know they have the condition, and two, because of various things like cost of travel and inability to access the services. So economic and government policy issues in low-income and middle-income countries. We know that because we do not have enough buying power, our health policies usually focus on child and maternal health. Like here in this country, we have something known as Beyond Zero, okay? And this looks at the mother and the newborn baby, mainly at the mother, providing services for them. We also focus on nutrition, immunization, and infectious diseases. So we really, because of scarcity of funds, we don't really have that much money to focus on non-communicable diseases, renal diseases being some of those. But the good thing is that in this country, through lobbying and advocacy, Kenya government has actually established 47 dialysis centers all over the country, and these are government centers, which are able to dialyze mainly the adults, but that's a huge step forward. People say that we are only giving 2 dialysis per week, but it's actually a very big leap because there were no such services in the past. The challenge of these renal replacement therapy centers is that they are not, they are not prepared, or they are not equipped to look after small children, so that our small children really cannot be dialyzed because the machines are not volumetric, and then the staff who are there are not really trained to looking after small children, those who are less than 20 kilos. And this is a picture of our president, and it just goes to show how we are accelerating universal health coverage. He's actually focusing on beyond zero, that's the mother and her child. We wish he was doing the same for our renal services, but we'll get there with time. So I found this paper which talks about pediatric kidney diseases in an African country, and I thought it was quite appropriate. It's a Nigerian paper, actually, in the Saudi journal. But basically, what they showed is a spectrum or pattern of pediatric kidney diseases, which is what we mainly see. We see a lot of nephrotic syndrome, and in Africa, we are seeing a lot of steroid-resistant nephrotic syndrome. We see a lot of these congenital anomalies of the kidneys and urinary tract infection. So Felicia said that there's been an epidemic of posterior urethral valves. Is it really an epidemic, or do we have a higher index of suspicion? I think that's what it is. And so we are diagnosing them more. And these are the ones which will end up on dialysis and requiring transplantation. When I think about them now, they give me nightmares, because I've got several kids who are born with it, and I don't know what to do with them. And their creatinines are so high. Soon they'll be requiring dialysis. I don't have facilities to dialyze somebody who's 1 year, somebody who's 2 years, and somebody who is less than 10 kilos or 15 kilos. Don't have the machines, I don't have the dialyzers. So it's a big nightmare, isn't it, Bashir? So what do I do with those people? I have to look for ways to do preemptive transplants, send them somewhere where these preemptive transplants can be done. So it's a big dilemma. Acute glomerulonephritis, that's infectious. Post-streptococcal glomerulonephritis is also a nightmare. And unfortunately, some of these may be diagnosed as UTIs, okay, until sometimes it's too late, because some of them go on to develop rapidly progressive glomerulonephritis and end-stage renal disease. UTIs, you think UTIs are simple, but they're not simple. If they go on to give you reflux nephropathy, then eventually some of those people will end up with hypertension and on end-stage renal disease and so on. I think last year there was a doctor who actually died of that, a lady died of that. It's really terrible. So UTIs are not as simple as they appear, and they are probably underestimated in these developing countries. And they should, if you have recurrent UTIs, be referred to a pediatric nephrology so that you can be adequately followed up, investigated, and so on. I think I need to point. I'll go. Chronic kidney diseases, they are missed, completely missed out in this country. And I think all over. Very sad that the other day I had a child who has been seen by so many doctors. She was presenting with failure to thrive and muscle pains. and she was put on calcium supplements and so on. But eventually, when she came to a good hospital, we found that she was very hypertensive. Her creatinines were 1,000. She was in pulmonary edema. She was in CCF, and her kidneys were small. So she's now on dialysis. So that's the tip of the iceberg. How many out there, because this is a child in the city, how many out there are not diagnosed and they die? And they're probably treated as rickets. Probably they're told they're malingering and so on. So then now we can look at AKI and also look at CKD. Now the incidence and even the prevalence of AKI in developing countries is actually not known because we don't keep registers, okay? It's quite, it's about 23.8% in the USA because they keep good registers. If you keep good registers, then you're able to plan your services. So we underreport our AKIs, and that's if we recognize them. Most of them we don't recognize. So they probably die at the periphery and so on. But I'm pleased to say that in this country, we've actually seen a decrease in the number of children who are presenting for dialysis. And this has been because of the active treatments that we have been doing. That is the IMCI and the ETAT and the ePulse. And so those who are trained are not just doctors. They are not just pediatricians. They are also nurses. And these nurses are the gatekeepers of the hospitals. So when they're triaging, they're able to see all those kids who come in with dehydration, alert the doctors, and then these children are rehydrated. And I'm pleased to say that very few of them then require dialysis. I'm happy to say that the initiative of this ETAT was actually one of the doctors whom we sent to America, a pediatrician, to do pediatric nephrology. But she decided she's not going to just treat the one case in the ivory tower. She's going to go out into the communities and do public health and public health education. That is Professor Grace Irimu. So she's done quite good, very well for that. So this is etiological distribution of ARF in children. And it's actually done data from people who are working in Somalia. And you can see that most of the problems that we get with AKI are because of infectious agents, snake bites, acute gastroenteritis due to all the rotavirus, typhoid, salmonella, shigella, HUS. Then there's pyelonephritis. Then, of course, we see the AKI that is associated with certain things like tumors and so on. And nephrocalcinosis, we don't see that much in Kenya, but I would say that in the northeastern regions and also in Somalia, where it is very dry, they see a lot of nephrocalcinosis. And then we get our tubular intestinal nephritis and so on. Not to forget our AGNs. Of late, we have been seeing quite a lot of lupus nephritis. Again, I think it's just because of a high index of suspicion, and we know how to recognize it, and when we recognize it, we do the appropriate investigations, and it turns out to be that. So, how many more such cases are we missing? I recall, sorry, I have to tell you so many stories as we go along. I recall a child whom I was called to see, no, actually who was referred from another hospital, had been going to Kenyatta for a long time, then went to another hospital, and all along she was being treated for idiopathic thrombocytopenia. Okay? When she landed in Gertrude's, I was shocked to see her skin. She was anemic, that is true, but she had this rash discoid lupus, that's what she had. And for a long, she even had the symptoms of the joint pains and the whatever, and she was being treated by hematologists. So when we did all the tests and we did the biopsies, it was indeed lupus nephritis. How many more are we missing who are in the hands of the hematologists, who are in the hands of other doctors? And then I must talk about the obstructive uropathies. Our pediatric surgeons, we need to work more with them as a team. Once they remove the obstruction, that's the last we see of that patient. Well, if we see the patient, if we are lucky. And those patients who have got obstructive uropathy often have renal dysplasia. And with time, slowly, most of them will end up with end-stage renal disease. So we need to harness are working with those people so that we do not lose such children. So we know that AKI is very dangerous, and that once you have it, you can go through all this spectrum, end up with kidney failure, death, and even if you recover from one AKI, you should be followed up. Are we following up our children? Or what do we do with them? We tell them once you're cured, it's okay. But if you've had AKI, then eventually you may end up with CKD and end-stage renal disease, so you do need to be followed up. So I've talked about this. I won't go about it. Now, end-stage renal disease, again, we don't know the prevalence in these developing countries. We really don't know. So we underreport it and we underestimate it, okay? But in those countries where they have studied it, we know that CKD is about 8 to 12% of the adult population. Now, because of that, we have hospitals that are reluctant to start dialysis treatment because they say they are not good for pediatric patients. They say that they are not going to get enough children, okay? And therefore, it will not be beneficial to them. And so this is a map of the chronic kidney diseases in children. But again, you see in Africa, it is completely white because it's underreported. So we need registers. So we have modalities of renal replacement in hospitals that are state-of-the-art, like the one that I work with. And you can see there we are doing automated peritoneal dialysis. This is a child who was stung by bees, and he's all swollen up, but with dialysis, he went into AKI because of the bee stings, but with AKI, with the dialysis, we managed to get him out of it. And this is one of our bigger patients who is on hemodialysis. Again, we are not able to put small babies, but for the bigger kids, we can actually put them on hemodialysis. So what are the barriers of treatment, of providing proper pediatric services, renal services in our country? This is because many of our patients are dying at home because of cost in transplantation, and some of them, and actually I saw a very good skit at Kenyatta where somebody was so sick and he was being taken to Kenyatta Hospital. The nurses were doing it, but he was apprehensive. He thought the building is so big, so beautiful, he was intimidated. He did not want to go in. He didn't know what to say to those patients. So patients are intimidated, they are apprehensive, and so we've got to find a way of making them be able to adequately access the services in our hospitals. So again, we have lack of trained personnel. We don't have enough pediatric nephrologists. I think, well, in this country we have about 4, but we need many more. And we need them to go into all the counties and run clinics where they'll be able to diagnose these patients. Unfortunately, after training, being very highly specialized, most of our specialists prefer to live in the cities, and that's a very big disadvantage. And then there's policy. Policy is so important. So we need people who can advocate for policy makers so that we can get certain issues pushed through Parliament. And national governments should address these inequalities. They should also improve community and parental awareness of kidney diseases, but they can't do this alone. They need stakeholders like ourselves. We need to have people, mothers and parents, who can also start advocacy for pediatric diseases. So we've talked about long distance of travel, because if I start a child on dialysis in Nairobi, I know that that child is not going to be very well dialyzed in Murang'a. And so they have to travel all the way because of the equipment that I'm using. And so within time, they stop coming. And of course, many of them will fall by the wayside and die. Now, there's also, when you talk about kidney transplant, there's a lot of apprehension. And Felicia talked about it, I think you remember yesterday. Who is going to give this child a kidney? And if this child is given a kidney, what's going to happen to that donor? Will that donor be able to live? And even if this child is given a kidney and this child has not been attending school for so long, will that change the quality of this life? So when parents question themselves like that, the natural way is that they give up and that child is left to die. Yes. So we need skilled multidisciplinary teams. We need an infrastructure that can support our pediatric and renal dialysis and transplantation. And we need to have campaigns to raise awareness. Now, we know that the International Society of Nephrology has an initiative which aims to reduce deaths from preventable and treatable AKI to 0 by 2025. And we have projects which are led by people like Minon, which is in response to this incentive. This is Saving Young Lives. And in Saving Young Lives, they're teaching dialysis to people, not just nephrologists, but even to pediatricians, even to nurses, so that that child who is at the periphery doesn't need to die. At least some dialysis can be started, and by the time they come, that child will be out of a critical state. Then it is very important, twinning with centers of excellence in developing countries is very important, so that we keep up with the knowledge and be able to manage these children. So in conclusion, I have said that in developing countries, there are many unmet pediatric nephrology issues. The barriers to provision of pediatric renal services involve government commitment and public knowledge. There's lack of government policies and commitment, inadequate infrastructure for provision of pediatric RRT, inadequate numbers of pediatric nephrologists, pediatric surgeons, pediatric urologists, and of course, pediatric kidney transplant surgeons, and of course, pediatric renal nurses, and more importantly, even the dietitians. So the diet that is given to our renal transplant, our end-stage renal diseases, is like that of the adults. And these are growing children, so you don't restrict calories, you don't restrict so much, because otherwise this child will not grow. There's inadequate public health knowledge of pediatric renal diseases. We've talked about cost, transport barriers. There are also cultural barriers. And so because of all this, many of our renal conditions remain undiagnosed. So we need to have people who can then go on to help us lobby. Sorry, one back. How do I go back? Anyway, that is the end of my lecture. I hope it's raised a bit of awareness about the situation of pediatric services in this country. And I hope that you will join us in this very big fight of trying to pull up the pediatric renal services so that at least, even if we are half of what the other services in this country are, not just in Kenya, but all over the world, developing countries, then we would have made a very, very big forge into the future. And we have champions like Minon, she's walked out, who are working very, very hard, not just for South Africa, but for the whole of Africa. So I hope that there will be many more champions like Minon. And so with that, I say thank you for your attention. I hope I've not bored you too much.